Bodies don't move after 12 hours. And if they do, they don't sound like that. I remind myself of that every time I step into the prep room past midnight, when the building feels hollow and the ventilation hum sinks into the walls. At 2:14 a.m., the fluorescents above the stainless steel tables flicker once then stabilize. A thin mist from the refrigeration units hugs the floor, catching the light in a way that looks almost deliberate. I clock in the temperature 38 degrees Celsius steady. That number is important. It means biological processes have stopped. It means everything is predictable. It means nothing should change on its own. I've been a funeral director for 14 years. I stopped counting the number of bodies I handled after 2000. At some point, routine replaces emotion. You do the 6-point verification. You check toe tag intake photo coroner's note, Form 42A refrigeration timestamp, and chain of custody signature. You don't think. You execute. Tonight was supposed to be one of those nights. The man on the table was listed as a 62-year-old from Franklin County. Natural causes. No trauma. No complications. Rigor mortis fully locked by hour 12. That was what the paperwork said. My gloves snap when I tighten them, a habit I don't notice until the noise echoes too loud in the empty room. The prep table is already elevated to working height, the head slightly raised per state guidelines. I adjust the surgical lamp, angle it to eliminate glare on the sternum area, then move to the instrument tray. Trocar. Occlusion clamps. Arterial tube with a 2:1 formaldehyde index mix. Forceps. A number 22 scalpel. Everything in place. The metallic tick sounds just as I reach for the intake log. One sharp, irregular tap. Like a piece of cooling steel contracting, except steel contracts evenly. Not like that, and not that close to me. It came from my left, not from the vent above the door where it usually echoes from. I glance up for 1 second longer than necessary. That's the first hesitation of the night. I don't like hesitating. Rigor should be complete by now. I say quietly, mostly to hear my own voice. It creates a sense of control. Hour 12. Full lock. I check the intake photo clipped to the folder. Right hand positioned neatly across the abdomen. Slight rotation inward, relaxed digits. The hand on the table isn't matching that. It's small, but the wrist is rotated outward a few degrees, just enough to notice, not enough to alarm anyone who doesn't do this work for a living. It should still be pliable at hour 2 or 3. But 14, now that joint should feel like hardened resin. I reposition it mechanically, lifting the wrist with 2 fingers to check resistance. It is stiffer than expected. I assume the intake tech simply misposed the hand during transfer. Happens sometimes, especially with new staff. Still, I check the refrigeration timestamp again. 14 hours, 22 minutes. Too late for any settling shift. Too late for anything at all. I push the anomaly aside and start the procedure. First step, artery location. I palpate the right carotid. Temperature is correct. Texture is normal for a case this age. No swelling, no delayed purging. I open the logbook and begin the standard shorthand notation, CR artery located. Tissue norm. No exudate. Halfway through writing the note, the metallic tick returns. Tick. Silence. Tick, tick. Pause. That rhythm doesn't belong in this room. I take a slow breath and look toward the refrigeration unit. Nothing. The coils aren't frosting or pinging. The sound came from closer, near the base of the prep table. But I don't go check. You learn not to give unusual sounds too much weight. Most of them have explanations. I continue documenting. I prepare the arterial fluid. 2 parts 20, index 1 part 36 index, diluted to 2:1 ratio per state prep guidelines. The fluid sits in the pump reservoir, reflecting the overhead light in a dull amber sheen. There's comfort in those ratios. Nothing changes them. Nothing challenges them. By the time I assemble the arterial tube and prime it, The room settles into its usual silence, a silence that feels appropriate for this work. Then I catch the hand again. Not moving, not different, just wrong. The angle of the thumb has shifted, only a millimeter, maybe less. But I was looking at that hand 15 seconds ago. The thumb was flush with the index finger. Now it's not. I move closer, leaning in, checking for airflow from the vents, checking my position relative to the table. Nothing external could have pushed it. Late-stage neuromuscular discharge, I mutter. The explanation comes automatically, the way someone says, "Excuse me," when they bump into a chair. Except the neuromuscular discharge window ends between 2 to 6 hours post-mortem, and we're at hour 14. Still, I pick up the wrist again, testing the rigidity. It's solid, locked. The fingers shouldn't have been able to shift at all, certainly not without lifting the whole hand. I write the detail in the logbook, then cross it out, then rewrite it, then cross it out again. A second hesitation. I don't like the pattern forming. I continue with the anatomical inspection. Skin tone is appropriate for cooling stage. Livor mortis distribution is fixed and predictable, deep violet pooling along the posterior weight-bearing areas. No blanching, no fresh migration, no surprises. The body is supposed to stay this way. I angle the lamp a little more and begin preparing for the carotid incision. The blade is sharp. I test it on gauze, let it bite through with the clean shearing sound I've heard thousands of times. Then I disinfect the incision line with phenolic solution, letting the strong chemical bite the air. A light burning smell mixes into the cold. 14 minutes into the prep, I hear the metallic tick again. This time it's sharp. Closer, under the table. The sound is so specific I instinctively step back. It's not fear. It's reflex, the same reflex you get when something brushes your leg unexpectedly. I crouch slightly and check the floor beneath the table. Stainless beams, no loose equipment, no dripping condensation, nothing that could tap. When I straighten, I glance again at the hand. The thumb angle is now identical to the intake photo. It's as if it reset. I stare for a full 2 seconds. Not long, not dramatic, but unusual for me. I don't stare during prep, I work. My chest tightens, not from fear, but from a shift in mental focus, the kind that comes right before you catch a mistake in paperwork or spot a missing line on a form. I look at the intake image again, then back at the hand, then back at the image. They match perfectly now. Yet they didn't a moment ago. I press my palm lightly against the sternum, checking for any remaining warmth. None. The skin is cold, consistent with refrigeration, consistent with death. Everything is consistent except the one detail I can't explain. I reposition the lamp again and start documenting the incision location verbally into the recorder. My voice remains steady, it always does when I'm working. But there's a slight hitch when I say the time code. Just one. Enough for me to notice, not enough for anyone else to think twice. The room feels narrower, not darker, just tighter. Like the air has shifted slightly toward the center of the room instead of flowing outward. The mist on the floor thickens around the base of the table, rolling out in a faint ring. Refrigeration units sometimes discharge heavier coolants at night. I've seen it before, but I've never seen it form that shape. I wipe my forehead with the back of my glove, another involuntary tell, and go back to adjusting the arterial line. As I lean in, the hand catches my peripheral vision again. I decide to ignore it. The routine demands progress. You don't stop a prep for something that small. You don't let imagination disrupt procedure. That's how mistakes happen. But before I can begin the incision, the metallic tick sounds for the third time. Tick, 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 tick. This time the rhythm is purposeful. A pattern, not random, not mechanical, not settling metal. I turn my head slowly, letting the silence stretch just long enough to anchor the moment. I look at the hand one more time. It lies perfectly still, perfectly positioned, perfectly identical to the photo. I inhale, steady, slow, calculated. Then I reach for the scalpel again. The blade slips in my grip only slightly, and that's enough. A third hesitation. I never hesitate 3 times. Not in this room. Not with the dead. But tonight, the dead aren't the only ones I'm watching. And they're not the only ones watching back. Bodies don't move after 12 hours. That was the last thing I told myself in Chapter 1, standing over him. Now I have a scalpel in my hand, and a suction tip in the other, and I'm inside his chest. The overhead lights stay at that same harsh white. The kind funeral homes in Ohio buy in bulk because they make everything look clean, even when it isn't. Condensation sits in a thin layer along the floor near the base of the refrigeration units. Stainless steel reflects white-gray and the dull yellow of the cavity fluid in the tray beside me. The metallic tick comes back before I even finish flushing the thoracic cavity. One sharp sound, then quiet. I pause the suction. The hum drops a notch. The room goes still except for the refrigeration compressor in the wall. My eyes go to the vent above the door, out of habit. No movement, no frost, no loose panel. I look back down into the open chest. The lungs are deflated. The heart is slack. The tissue color is appropriate for a man refrigerated at 38 degrees for 14 hours. No frothing, no unexpected bleeding, no new lividity. Everything in front of me says finished. Everything in the air says wait. I keep working. I irrigate the thoracic cavity with warm water and cavity fluid. It runs clear after a few passes. I follow the same sequence I've followed for years in this prep room in Franklin County. Drain, inspect, pack, seal. The state board doesn't care how I feel about a case. It cares that I follow procedure. At minute 16, I shift my weight slightly and slide the suction tip along the lower ribs. That's when it happens. The left index finger drags across the table. It's small, a tiny scrape of skin on steel. No more than a millimeter. I don't see it move. I hear it. The sound is distinct. Not the high ring of metal on metal, a softer scrape. Friction from something that should be locked in place. My eyes go to the hand automatically. The fingers are in a slightly different position. The index finger is not flush against the middle finger anymore. There's a sliver of space. The nail sits closer to a faint smear of moisture on the steel. My first thought is mechanical, always. I check for any slope in the table. None. The hydraulic mechanism is locked. The surface is level. There's no pooling fluid under the hand. No cloth beneath it. Nothing to slide on. Residual neuromuscular discharge, I say under my breath. The words come out flat. Practiced. They sound like what you're supposed to say when something like this happens within the first few hours post-mortem. You remind yourself of muscle fibers, of stored ATP, of discharge patterns. But 14 hours at 38 degrees is beyond that window, even for edge cases. I set the suction tip back in its holder and step around the table. 1 step, 2. My shoes squeak lightly on the polished floor where condensation has gathered. I pick up the left hand. The wrist is rigid. The fingers resist. They don't flop or sag. They move as a single unit when I apply pressure. That stiffness fits the timeline. The position does not. I glance at the intake photo clipped to the folder on the rolling stand. Right hand across the abdomen. Left hand resting straight, fingers together. They wouldn't see a millimeter in a photo. I know that. But I do this work every night. I know how a hand looks when it's been resting in the same position for hours. This doesn't look like that. I write it down anyway. 02:30, possible late reflex in left index. I pause. Then I add, no visible cause. Table level. I stare at the sentence for 3 seconds. Then I draw a line through it, not because it didn't happen, because I don't like how it reads. I try again. So 02:30, minor finger shift observed. Likely transfer artifact. Another pause. Another line through the note. I feel the pen dig into the paper harder than it needs to. The tip almost tears through the log page. That's the first controlled frustration of the night. I clamp down on it fast. I don't slam anything. I don't raise my voice. I just close the logbook a little more firmly than necessary and set it aside. Back to work. I reposition the left hand. I press the fingers together, straighten them and place the hand exactly where I want it. Palm down neutral, what we call viewing safe in the prep room. No one uses that term in front of families. It's internal slang. It means the hands won't look tense or clawed when we dress him. I check the clock on the wall. 02:32. Temperature monitor on the refrigeration unit still reads 38 degrees. No drop, no spike. I move back to the chest and resume packing the cavity. Cotton cavity fluid cotton again, even layers, no gaps. I narrate into the recorder in my usual tone. Thoracic cavity cleaned, no unusual exudate, no intracavity gas pockets. Packing initiated at 02:33. My breathing is even. My hands are steady. That's important. I can acknowledge unease without letting it into my movements. That's the line between a professional and someone who shouldn't be in this room. The metallic tick comes again while I am mid-sentence. Tick, tick, pause, tick. This time it matches my heartbeat, or I think it does. I can't tell if it's in the room or my head. It feels closer to the table again, not the wall. I stop the recorder. Silence rushes back in thick, unnatural. The suction pump is off. The only steady sound should be the compressor. I listen. Nothing. I restart the recorder without commenting on the noise. I don't want this on the audio file twice. Once would already sound like I was distracted. I finish packing the cavity and move toward the left side of the table again to adjust the arm before I start on the abdomen. And I freeze. The fingers are not where I left them. The hand is still palm down. The wrist is still rigid. But the fingers have curled in just slightly, as if beginning to form a loose fist. The index and middle finger now angle inward, creating a gap between them and the ring finger that was not there before. It is small. It is deniable. It is impossible. I don't say anything. I don't move for a full count of 5. I just look. My jaw tightens. That's the first involuntary reaction I can feel. I unclench it, slowly aware of each millimeter of release. These are the things I control when the job begins to push back. I reach out and press lightly on the knuckles. The skin is cold. The joints resist extension. The hand behaves like it's been in rigor for hours. 14 hours, 34 minutes, I say quietly, looking at the clock again. I want that number in my memory. The livor mortis on his back hasn't changed. It's still fixed in the dependent areas. Deep purple along the scapulae, lower back, and calves. No new blanching, no new migration. Gravity is doing what gravity should. Only the hand is trying something different. I check the arterial line setup on the other side of the table just to have something normal to look at. The pump is primed. The tubing is clear. The formaldehyde mixture has the right opacity. No clouding, no separation. Everything there makes sense. I give myself that 30-second reset, then I go back to the hand. I take the intake photo off the clip and hold it closer. I align it to the real hand as best I can. There's no angle where they match now. The photo shows a relaxed hand, The hand on the table is on the way to becoming a curl. I know fingers can move during transfer. I know staff can bump a limb during a shift. But transfer ended hours ago. There is no one else in this room. The prep table has not moved. I have not bumped it. I pick up the pen again. 0236, progressive digital flexion left hand. Unknown cause. I stop. My handwriting looks wrong. Tighter angled, not my usual block print. I draw a line through that sentence too. Don't do that, I tell myself, barely audible. You saw it. Write it. I flip to the next line. 0236, left hand position no longer matches initial documentation. No external force observed. I leave that one. For now. I set the logbook down and flatten my palm on the table next to his hand, but not touching it. The steel is cold through the nitrile. The prep room feels smaller again, not darker, just closer. The metallic tick comes a third time, not from under the table, not from the wall, from directly beneath my hand. A high, tight tap transmitted through the steel into my gloved palm. It vibrates faintly up my arm. It's not strong, it's not dramatic, but it is centered under the left wrist. I pull my hand back on reflex. No more controlled, slow movements. Just a quick recoil. I don't pretend it's anything else. I look straight at the wrist. The fingers don't move now. They are fixed in that slight flex. The nails are closer to the table surface. There is a faint, thin line on the steel barely visible in the lamplight. A straight mark as if something scraped along it. I don't touch the hand again. Not yet. Instead, I grab the thermometer probe and place it against the skin near the radial artery. The monitor beeps after a few seconds. 38 degrees. Still, no change. No reason for any fresh contraction. No reason for a late-stage twitch. No reason for anything I've just seen, heard, and felt. I want to tell myself I imagined it, that I misheard the tap, that my palm amplified something it shouldn't have. But the straight line on the table is still there. It's small. It's real. I reach for a clean swab and wipe the line. It doesn't disappear completely. Something has abraded the steel lightly. I put the swab in the waste bin and realize my hand is shaking. Not much. Just a fine tremor when I hold it up at eye level. I close it into a fist until the tremor stops. Then I flex my fingers out again, slow, deliberate. I'm not tired, I say softly. I've done doubles. This isn't that. There's no one to argue with me. The body certainly doesn't. I reposition the hand one more time. Fingers straight, palm flat, neutral for viewing. I tell myself this is about respect, about presentation, about doing the job correctly even when details don't behave. I stand there until I'm satisfied it's as it should be. I walk back to the other side of the table and pick up the suction again. I lean over the open chest to resume the work I'm actually here for. For exactly 3 seconds, I let myself believe that whatever happened with the hand is over. Then, without touching it, without any air current, without any shift on the table, I can see or feel the left index finger bends again. Slow, deliberate, downward. When it stops, the nail hovers exactly over the faint line on the steel that I tried to wipe away. I don't record that part in the log, What I write instead is simple 0240 hand adjusted for presentation. Nothing more. Later when I try to sleep, that's the sentence that keeps me awake. Not the sound, not the scrape, not the movement. The fact that for the first time in 14 years, the log says I moved something, and I know I didn't. I wrote 0240 hand adjusted for presentation. Every time I look back on that night, that line is the point where the facts and my memory start to separate. I did not move that hand. But my log says I did. By the time I start on the abdomen, the wall clock reads 0247. The room looks the same as it did at the beginning of the prep. Same harsh white from the overhead fixtures. Same cold mist rolling low around the base of the refrigeration units. Same faint chemical smell from the phenolic disinfectant we use because the cheaper stuff stains the steel. The body should be the same too. I check the monitor on the refrigeration unit one more time. 38 degree Fahrenheit. Still, no variation. I say it out loud. 38 stable. It keeps my head in the numbers. Ohio's board inspections are strict on documentation, especially on refrigeration logs. If this ever gets audited, the temps will be the first thing they look at. The livor mortis on his back is fixed. Deep purple along the posterior. No new blanching when I press a gloved finger into the skin. The pattern is what you expect when a man lies supine for 14 hours. The posterior vessels give up first. Gravity finishes the rest. Nothing there bothers me. It's everything above the table that does. I reposition the surgical lamp so the beam runs straight down the center line of the torso. The color palette in the room stays consistent, white-gray steel. The dull yellow of cavity fluid in the tray, the faint red-brown along the incision lines. It's a clean scene on paper. I pick up the trocar. It has weight from years of use. Our embalmers call it the old one, even though we have newer sets. The newer ones are lighter. The old one gives better feedback in the hand. You feel resistance in the tissues in a way plastic handles never give you. I attach the suction hose, check the connection twice, and pivot the trocar toward the upper abdomen. This is routine. After the thoracic cavity, you confirm there are no remaining gas pockets in the intestines. You don't want bloating during viewing. Families notice swelling before they notice anything else. The metallic tick returns as I line up the entry point. Tick. Short pause. Tick, tick. It comes from somewhere near the base of the table again, not in the walls, not the compressor. I feel it in the soles of my shoes this time, a tiny vibration through the thin prep room mats. I exhale once through my nose. The breath is a little shorter than it should be. Stay with the procedure, I tell myself, just loud enough to hear it under the hum of the pump. I mark the trocar site 2 fingers above the right iliac crest and begin the insertion. The instrument passes through skin, subcutaneous fat, and into the abdominal cavity with the usual sequence of resistance points. I feel the give where it should be. No obstruction, no adhesion. I angle it toward the center line and begin aspirating. The sound through the hose is what I expect at first. A hollow draw. Some residual fluid. Nothing dramatic. I watch the tube for bubbles. There are none. The bowel should be quiet now. Almost empty. At 02:52, the abdominal wall under my hand changes. It is slight. A shift in tension, a sense that the tissues are no longer just receiving the instrument, but reacting to it. The surface under my palm feels firmer for a second. Then it lifts. The abdomen rises. It is not a quick jerk. It is not a random twitch. The entire upper abdominal wall lifts and falls in a slow, shallow movement that mimics a weak inhale. Up, hold, down. My first instinct is to check that my other hand isn't pulling on anything. It isn't. I am steady. My elbow is braced off the table like always. I look at the man's face. The eyelids are closed. The mouth is set in the neutral line I created with feature setting earlier. No air passes over the lips. There is no condensation. The throat remains flat. The abdominal wall rises a second time. Same cadence, same shallow arc of movement. No gurgling from dislodged gas. No audible shift in the intestines. Just a slow lift and fall. This is not how gas behaves. Diaphragm should be done. I say voice flat like I am reading from a textbook for a licensing exam. 14 hours, full collapse. I angle the trocar upward toward the diaphragm and aspirate again harder. If there is any gas left, It should release now. The suction sound does not change. The tube remains mostly clear. There is no spray, no froth. The abdomen still rises. A third time. Up, hold, down. The movement matches timing you only see in a ventilated patient. Not rapid, not erratic. A shallow pattern that would read as low respiratory effort if the man were in an ICU bed instead of on my table. I check the refrigeration temp again on instinct. 38 degrees? There is no internal heat source to create expansion like this. No enzyme activity, no active gas production. The cavity work should have ended any chance of this. I feel my jaw clench. I force it to relax. My hand on the trocar tightens for a moment, then loosens. I adjust my grip so it doesn't look like I am strangling the instrument. Residual transfer gas, I say. It is the only explanation left, and it is thin. The metallic tick follows as if in response. This time it travels. It begins at the foot of the table, a sharp sound through metal. Then another mid-length. Then a third directly under the abdominal area where my hand is. Tick, tick, tick. Each tap feels closer, as if it is moving up the steel supports. The vibration reaches the point where my hip leans against the table. It is not strong. It is enough to be undeniable. The abdominal wall lifts with the final tick. It holds a fraction of a second longer this time. I pull the trocar back half an inch. The movement stops. I stand absolutely still. No sound, no motion. The suction pump hums on steady and indifferent. The abdominal wall remains flat for 10 seconds. 20. 30. Nothing. I slide the trocar forward again in the same track. The abdominal wall lifts. It is the same pattern, the same shallow arc. My hand feels the expansion through the glove. The sensation is wrong. It is not bubbling gas. It is coordinated motion under tissue that should be inert. I pull the trocar out completely. This is the first deliberate break in procedure I allow myself. I disconnect the suction and set the instrument in the tray, metal against metal. I shut off the pump. The room goes quieter than it should. I check the man's face again. No change. The sutures at the mouth hold. The eyelids stay smooth. There is no movement in the neck. The abdomen falls and rises one more time with no instrument in it. Up, hold, down. This is the moment I decide I don't want anyone else in the room until I understand what I am dealing with. I step back and reach for the intercom button on the wall by the door. "Can you check the fluid index on the main unit?" I say, when my assistant answers. My voice sounds normal. The shelf batch. I want to be sure we're still at 2-1. Now he asks. "Yeah," I say. "Before we run the next case, take your time." "Got it." I hear the click as he disconnects. That is the extent of our dialogue. No questions, no comments. In this line of work, if the director says, "Recheck you," recheck. I wait until I hear his footsteps fade down the hallway. When I'm sure he is in the supply room and not near the prep door, I turn back to the table. It is just me and the body now. I place my hand flat on the man's abdomen. The skin is cold under the glove. The shape is correct. No obvious bloating, no visible distension. To anyone walking in, this would look like any other prep halfway done. I keep my hand there. 10 seconds. 20, 30. Nothing moves. I press a little harder, testing for any residual gas. The tissues feel firm but not rigid, the way they should after cavity work. There is no shift in viscosity, no bubbling. I remove my hand and watch. The abdomen rises. Not a lot. Enough that I can see the change in the angle of the light on the skin. Enough that the shadow under the lowest rib deepens for a moment. Then it returns to baseline. I look at the clock. 02:58. 4 minutes since the first abnormal lift. Long enough that any random shift should have shown itself once and ended. This is a pattern. The metallic tick follows again. Not 3 separate taps this time. One long dragging sound through the metal supports, like something exerting steady pressure upward. I feel it in the table legs, then in the floor under my shoes, then faintly in my teeth. The abdominal wall rises again in time with the sound. Up, hold, down. It is the closest thing to breathing I have ever seen in a body that is supposed to be beyond that possibility. I check the diaphragm line with my eyes tracing the invisible boundary under the ribs. During initial exam, it was flaccid. I put that in the report. There is no rational way for it to be re-engaging now. Not at this temperature, not at this timeline. In that moment, I feel something I do not like admitting. I doubt my own documentation. I replay the earlier steps in my head. Did I misjudge the diaphragm? Did I misread the cooling time? Did I miss a gas pocket during thoracic aspiration? Every scenario ends at the same wall. It should not behave like this. I take a step back and pick up the recorder again. 0259, I say. Abdominal motion observed. Pattern is shallow and rhythmic. No gas sound, no visible distension. I stop. My throat feels tight. I swallow once to clear it. Refrigeration temp remains at 38, I add. I want that on the audio. No external vibration source visible. I put the recorder down and move to the lower end of the table. I kneel briefly, ignoring the discomfort in my knees on the hard floor, and look along the steel supports. There are no loose bolts, no visible damage, no rolling carts touching the frame. Nothing is pushing from outside. I stand, wipe a thin line of condensation off my glove onto a towel, and turn back to the body. The abdomen is flat again. The next movement doesn't wait for me to be ready. The abdominal wall lifts and holds for almost a full second longer. Then it drops. The metallic tick fires at the same time from directly under the center of the table. This time, I don't speak. I don't write. I just watch. On the third repetition, I notice something new. The movement is not uniform. The right side of the abdomen lifts a fraction of a second before the left. There is a slight rotation in the skin tension, a shift that suggests muscle fibers engaging in an order that requires an intact control system. Gas does not sequence like that. Decomposition does not coordinate like that. Somewhere between the fourth and fifth rise, my control slips. I slam the flat of my hand down on the edge of the table. The sound is sharp in the room, not loud enough to carry beyond the door, but loud in my own ears. The instruments in the tray rattle once and settle. Stop, I say. One word, still quiet. Not a shout, but not neutral. The abdomen stops moving. The silence that follows feels heavier than before. The refrigeration hum seems further away. The light seems brighter. The chemical smell from the disinfectant feels sharper in my nose. I stand there with my hand on the steel, waiting for something to happen. Waiting for proof that what I saw was a remnant reflex or a misperception. Waiting for anything that would make sense. Nothing comes. The abdominal wall stays flat. The metallic tick does not return. I look at the clock one more time. 03:02, 4 minutes, 6 lifts. One pattern I cannot explain. I reach for the logbook. My hand hesitates over the line where I should record it. I feel the pen in my fingers heavier than it should be. I write 0302, further abdominal activity suspected. Will monitor. I close the book before I can think of better words. Later, when I play the audio back, I will notice something that doesn't match. The timestamps on the recorder will drift by a few seconds from the clock I looked at on the wall. Not much. Just enough to raise a question. I will ask myself if I misread the time. if my eyes flicked between numbers without registering them correctly. But standing in that prep room with my hand still pressed against the steel edge of the table and the skin over that abdomen perfectly still, the only question I had was simpler. If it wasn't gas, and it wasn't me, what exactly was trying to take that breath? What took that breath doesn't stop with the abdomen. It moves higher. By 0306, I'm back at the head of the table. The suction pump is off. The trocar is resting in the tray. The room is still white and steel and cold, but the air feels heavier dense across my shoulders. The refrigeration monitor at the far wall still reads 38-degree yellers in green numbers that do not care what I just saw. I place my hand on the sternum. The chest wall is flat. The ribs are where I expect them. No expansion, no collapse. If someone from the state board walked in right now, they would see a normal case. They would look at the incision, the line of the jaw, the positioning, and sign off. I watch the chest. 10 seconds. 20, 30. It rises. Not sharply. No jerk. The entire anterior chest lifts in one smooth movement, just enough to change the angle of the light across the skin. The motion holds for a second. Then the chest returns to baseline. The pattern matches what I saw in the abdomen. Same interval, same shallow depth. This should not be possible. The diaphragm was soft during the initial exam. I documented that. The thoracic cavity was aspirated. I did that myself. Gas that could simulate this would present with gurgling distension, irregular movement. This is controlled. The sound comes next. Not the metallic tick I've been hearing since the beginning of the prep. A new noise. Closer. Wet. When I press my palm lightly into the sternum, I feel it. A slow, sliding scrape under the gloved hand. Tissue moving against tissue in a way that requires tone, not slack. It is faint, like muscle fibers are adjusting inside a field of resistance. I move my hand away. The sound stops. I look at the clock. 0307. 14+ hours since refrigeration. Rigor mortis at this point should be fully established. Livor mortis fixed. No circulation. No muscular control. I need to go back to something I can measure. I adjust the surgical lamp again, narrowing the beam so it tracks the chest and upper abdomen. The rest of the room drops a shade darker. The prep room in Franklin County is not large. 2 tables, 1 counter, a small sink, a wall-mounted CCTV unit that the owners installed after the last state inspection because Ohio now pushes for continuous documentation in care of remains areas. The camera over this table feeds into that unit. The monitor shows a frozen image of the case from a few minutes earlier. There is a time code at the bottom. It reads 030512. The wall clock above the door reads 0307. 2 minutes off. I tap the glass of the monitor once with my knuckle. That is my one frustration. Small, controlled, enough to register, not enough to crack the casing. The image on the monitor jumps. The angle shifts a little, then freezes again. The time code moves forward by a few seconds and stops. I check the other camera feed with a quick toggle. The empty table beside me shows real time. The second feed's time code matches the wall clock down to the minute. Only this room, only this table, only this body. I step back to the case. The chest is still. I pick up the recorder and hold it closer than I need to. 0308, I say. Chest motion observed. Interval appears regular. No gas sounds. No external vibration detected. My voice sounds even. It doesn't match the tightness in my throat. I set the recorder down. There are still tasks to complete before this man can be dressed. The right shoulder incision for arterial access needs to be extended and cleaned. The tissue edges need to be trimmed before suturing. I pick up the number 22 scalpel again. The blade is sharp. We changed it before this case. The handle is the standard stainless we use, not the disposable plastic. The weight is familiar. Stable. I place the tip at the margin of the previous cut on the upper chest and press. The blade meets resistance it should not meet. The top layer of skin opens as expected, but the underlying tissue does not separate the way relaxed muscle and fascia do at this stage. It pushes back. It feels like cutting into a tense muscle during surgery, not a dead one on a prep table. I increase pressure slowly. The scalpel advances, but instead of a clean glide through inert tissue, there is a dragging sensation in my hand. The muscles under the blade feel tight. They pull against the cut. I stop and lift the blade. There is no bleed, no fluid seep. The only sign that anything is different is the white tension line just under the surface. I press again a few millimeters higher. Same resistance. Same drawn-out separation. I speak into the recorder without looking up. Noted. Tension abnormal. Rigidity inconsistent. The last word comes out lower, quieter. There's a slight tremor at the end of the sentence. You can hear it if you play it back enough times. The wet scrape returns. It starts in my glove fingertips this time. A sliding sensation like the tissue is pulling back from the scalpel and then returning, pressing against the blade. I lift my hand away from the chest entirely. I hold it in the air and watch. The skin along the incision line tightens. It is visible in the overhead light. A subtle narrowing pulling the cut slightly closed. Not all the way. Enough to change the shape. The chest rises again, up, hold, down. The movement repeats with almost perfect spacing. I could set a metronome to it. This is no longer about gas finding a new path. This is a pattern. I press my fingers lightly against the back at the scapula area. Livor mortis should still be pooling there. Deep violet, fixed, no movement. It isn't. The color that has been set since refrigeration began is fading. Very slowly. The violet is thinning, shifting to a dull bluish tone. The edge of the pooled area recedes a fraction of a centimeter toward the spine with each breath I see in the chest. I track it with my eyes. Chest rise, back color lightens, chest fall, back color shifts again. This is what would happen if the blood were being moved. Not much. Not through a beating heart. Through some change in internal pressure that is enough to unsettle what gravity already claimed. No circulation should exist now. No blood flow. No vascular tone. The vessels should be static conduits, nothing more. Liver should be fixed, I say under my breath. This timing, this temperature. It should not move. It is moving. I take my hand off his back and check the refrigeration monitor again. 38 degrees Fahrenheit. No warming, no malfunction, no reason for this. For a moment, I wonder if this is some extremely late postmortem effect I missed in training. Some edge case described in one of the Ohio coroner's bulletins that I skimmed and filed without reading closely enough. 14 hours plus, I say. You don't do this at 14 hours. My hand returns to the chest. I feel the next rise under my palm. It is stronger. The ribs lift into the glove. The sternum pushes up. The wet scrape is louder now. It is not just tissue moving inside. It is the sound of structures under tension rubbing in ways they are not supposed to. The chest lowers. The scrape ends. I check the wall clock. Zo3:11. We are not talking about one anomaly anymore. We are 5, 6, 7 cycles into an event that has no supporting literature. Not in the texts we used for state board prep. Not in the continuing education modules every license holder in this state has to complete. I step away from the table. I need a reference point that is not my own senses. I go to the CCTV monitor again and watch the frozen image. Time code 030936. 2 minutes behind. I glance up at the wall clock, then back to the monitor. The delay holds. Same offset as before. The picture still shows an earlier stage of the prep. The abdomen not yet packed. The chest with a shallower color gradient. No movement. I switch feeds again. The empty table is live. Its time code and the wall clock match to the second. I return to my case. I do not try to adjust the camera again. At 03:12, the chest rises without my hand on it. It looks for all functional purposes like an attempt at respiration. No airway, no lung function, no metabolic demand. Just the mechanical part. The expansion, the hold, the release. The livor mortis along the back continues to shift. The purple is now limited to the lowest lumbar region and the backs of the thighs. The upper back takes on a more general pallor. The skin over the ribs and flanks turns a flat, cold gray that I associate with bodies that have been moved and held in new positions. I have not moved him. I put my hand at the edge of the pooling near the mid-back. I press down. For a moment, the color lightens under my glove. When I lift my hand, the purple does not return. It fades further toward the lower body with the next chest lift. This is redistribution. It should require some mechanism of internal pressure change over time. That mechanism should not exist here. The wet scrape under my hand lengthens. What began as a faint slide is now an extended drag during each motion. It feels like a structure is trying to move and encountering resistance it should not encounter. The sound is not loud enough for a family in the visitation room upstairs to hear. It is loud enough that I know, if I pretend I misheard, I am lying. I pick up the recorder again. 0313, I say. Livor mortis no longer fixed. Pooling appears to be draining superior to inferior, correlates with chest movement. I pause. My breathing is not as steady now. There is a hitch between words. Tissue tension at incision sites is inconsistent with expected flaccidity. Resistance present. I stop the recorder. I want to say more. I don't. Anything beyond that crosses a line between documentation and speculation that the licensing board reads carefully. I set the recorder down a bit harder than necessary. The plastic case clicks against the metal tray. That is the second time tonight I have let force bleed into an object. Once on the monitor, once here. I go back to the chest with the scalpel. I test the edge of the previous cut again. I expect resistance now. It still unsettles me when I feel it. The tissue pushes back against the blade in a way that implies muscle fibers under active tension. The chest lifts again under my hand. Up, scrape, hold, down. A small line of fluid at the incision edge beads up and then withdraws, pulled slightly inward, not outward. Fluid does not retreat. The olfactory note in the room changes by a fraction. The usual chemical and mild organic odor of a prep gives way to something closer to what you smell in an operating room just before closing. Warm tissue under lights. The refrigeration monitor still reads 38 degrees Celsius. I know how absurd this sounds when laid out in one place. It is different when you stand there and watch each detail build on the previous one, each well within the boundary of possibility, until you put them together. The chest lifts again. I count the seconds between movements now. 7 seconds. Lift. 8 seconds. Lift. There is a crude regularity. Not precise like a machine. Consistent enough to be intentional. I press my palm flat against the sternum and do not move. The wet scrape moves with my hand this time, tracking along the contour under my glove. It feels like whatever is shifting inside is responding to the pressure-changing route. Hold the line, I say, replicating the phrase we use when we want an assistant to maintain an arterial clamp. There is no assistant in the room. I say it anyway. The chest stops moving. For a full 20 seconds, there is no expansion, no scrape, No liver shift. The body behaves exactly like it should have from the moment they rolled him into this room. I remove my hand. Nothing happens. The silence is almost worse than the movement. I look at the wall clock one more time. 03:15. 9 minutes of events that, if I chart them accurately and honestly, will read like I have lost the ability to interpret basic postmortem findings. I move to the logbook. I open it to the current page. There is a long, empty line waiting for the next entry. My pen hovers. I could write no further anomalous movement observed. I could write prep completed without complication. I could close this gap with a sentence that protects my record. Instead, I write 03:15 chest motion and livor redistribution ongoing. No known physiological basis at this stage. I stop there. I close the book. Later, someone could say I exaggerated. Someone could say I misinterpreted what I saw. Someone could argue gas or delayed rigor or equipment malfunction. But if they line up the audio, the logbook, and the camera feed in this room, they will find one more detail that doesn't fit. When they freeze the frame at 03:13 on the CCTV clip, they will see my hand pressed on the man's sternum and his chest perfectly flat. The time code under that frame will read 03:11:02. The wall clock in the background of the same shot, half reflected in the stainless surface, will read 03:13. 2 different times for the same second. One of them will be wrong. I still don't know which. I still didn't know which time was wrong when the room finally broke me. By 03:18, the notes are done for now. The logbook is closed. The recorder is on the tray beside the arterial pump. The refrigeration monitor still glows 38 Widwarisgumps, steady green against white tile and stainless steel. The chest has gone still again. The livor along his back has settled into a new pattern I don't want to study any further. There are only 2 major tasks left before I can even think of cosmetics' final cavity check and cranial work. I tell myself if I move forward, the procedure will pull everything back into a shape I recognize. The metallic tick comes back as I adjust the lamp toward his face. 1 tap, a second. Then that faint, trailing scrape through the table legs. I don't pretend it's the compressor anymore. I just file it away in the same place I've put the chest movement and the shifting lividity under a heading called Review Later, which is another way of saying not now. I raise the head of the table a few degrees with the hydraulic foot pedal. The mechanism hisses softly. The man's chin angles down, then stabilizes. We do this before shaving or setting features. It's basic prep room routine in Ohio. Visitation rooms upstairs don't forgive bad angles. I check his eyes. They are closed. The lids are smooth. The eye caps I placed earlier are seated correctly. There is no bulging, no leakage, no clouding at the edges. The mouth is still secured, mandibular suture holding. No slack in the jaw. By every standard, I know he is ready for the last stretch. I tell myself that and pick up the razor. We use disposable cartridge razors for this part. 1 per case. Never reused. I run warm water over the cartridge from the prep sink, then shake off the excess and move back to the head. The light is harsh on his skin, white flat and clinical. It flattens everything to the same color range, pale gray, faint yellow. The dull purple at the margins, where liver used to be heavier. I stretch the skin along his right cheek with my free hand and begin short, slow strokes with the razor. The drawer of the instrument cart rattles behind me. It is a small vibration, just enough to make the metal handle click against the frame. Enough that if I were working on the abdomen, I could ignore it. I pause the razor over his cheek and listen. The wet scrape answers. Not from the chest this time. Higher. It runs under my fingers on his face. The sensation of something inside the neck and mandible area adjusting, sliding, resisting. I let go of his cheek. The skin pulls slightly back into place. The sound stops. I check the wall clock. 03:19. Rigor mortis at this point should be solid in the neck. Earlier chest and abdominal movement were already beyond what should occur with this timing and temperature. The cervical area should be the most locked of all. I place the razor in the tray for a moment and switch to gloved fingertips only. I press lightly along the side of his neck, just above the clavicle where the sternocleidomastoid attaches. The tissue is firm, stiff, consistent with his hours in refrigeration. I increase the pressure. The muscle under my fingers tightens. It is a subtle change, a small, incremental increase in tone, as if something inside is bracing against the contact. The skin does not move. The underlying structure does. I take my hand away. The metallic tick fires again directly through the frame of the table at my hip. Tick. Pause. Tick, tick. The stainless tools on the small auxiliary tray at my right vibrate once. Forceps shift a few millimeters. A hemostat rolls and bumps against the arterial tube clamp. I look at the refrigeration monitor again. 38° Celsius? No drop, no spike, no alarm. I return to the head. I do not want the assistant in here for this part. We all have lines we don't show each other crossing. I pick up the razor again and finish the right side of his face. Each stroke is steady. My hand knows its path. I rinse the cartridge once more, wipe off stray hairs with a piece of gauze, and work along the left side. It is almost calming. Short, straight motions. Clean contact with the skin. No nicks. When I'm done, I set the razor in the sharps container and reach for the towel to wipe away the last residue of foam. That is when the head moves. It does not rotate fully. It does not lift off the headrest. The change is small, but it is deliberate. The chin shifts a few degrees toward my right, like the neck is turning to follow where I moved. There is a sound, not a click, not a pop. A wet grinding friction from deep in the neck. The kind of noise you hear when rigid structures under pressure are forced to slide past each other. I freeze. My hand is still halfway to the towel. The room is silent except for the refrigeration hum and a slight ring in my left ear from how fast my pulse changed. I watch the neck. The skin over the cervical area shows new tension lines. The platysma pulls. The sternocleidomastoid stands out faintly. The head holds the new position. For the first time tonight, I do not reach for an explanation. I step closer instead. I put my right hand on the side of his skull fingers, along the temporal area thumb near the tragus. I apply gentle pressure to see if there is any mechanical give from a loose head block or slip in the headrest. There isn't. The skull is seated. The support is stable. I push a little further enough to test the limits of the neck. The grinding comes back, not from the block, from him. It is not a clean pivot. The movement is irregular like stiff muscle fibers, and already set ligaments are being forced to stretch. There is a layered resistance in the tissues that I can feel through the glove, as a series of small catches. I let go. The head doesn't return to center line. It keeps the slight rotation now angled a little more toward where I'm standing. I feel my jaw tighten in response. I exhale through my nose slow and even until the pressure eases. Rigor shift, I say quietly. It is a meaningless phrase at this point. There is no documented rigor shift like this at 14+ hours in a cooled prep room. I reach for the towel again. Simple task. Wipe his face. Reset small details. Maintain appearance. As I bring the towel up, his eyelids move. First, a faint flutter. That can be explained. Postmortem movement of the lids can happen if there's any residual tension. Eye caps can slip. Sutures can pull. They open further, not fully. Just enough that a thin crescent of dull corneal surface appears between lid and lash. The arc is not random. It follows the motion of my hand as I move the towel. Up, hold, down, I stop mid-wipe. The room narrows. Not literally. The distance between me, the table, and the walls feels shorter. The air is colder. The skin on the back of my neck tightens. The wet scrape shifts to a new area. Behind the eyes. It is faint but present. A subtle sliding, the sense of the globes adjusting against inner structures that should be fixed in place by now. I lower the towel. I move my hand slowly to the left, out of his direct frontal axis. His eyes track. The slit of visible cornea slides along under the lid, following the direction of my hand. The movement is not smooth. It is a slow, broken pivot, like something is trying to overcome a resistance it should not be able to fight. I move my hand back to the right. The eyes follow again, fractionally delayed, but aligned. There is no air in his lungs, no circulation, no active neural activity that any coroner in this state would certify as compatible with life. But his gaze is following my hand. I feel my grip tightening around the towel. The fabric bites into my palm through the glove. That is my second slip tonight. I force my fingers to uncurl. This is not possible, I say. Those are the only 4 words I'd let myself have. They hang in the air between us. The prep room absorbs them. The refrigeration hum continues unconcerned. The metallic tick hits then, directly under the head of the table. One loud tap, then another, then a longer dragging vibration. The stainless tray beside me trembles. Scissors rattle against forceps. An arterial tube rolls in place and bumps against the stand. The room temperature feels like it drops 5 degrees. The hairs on my forearms prick under the gown sleeves. The parts of my face not covered by my mask feel tighter in the cold. I glance at the monitor. 38 degree enough. No change. No visible reason for the cold to deepen. I look back at him. The eyes are still in that thin, open position. The corneas are dull, but there is alignment in the movement I just saw that has nothing to do with gas or withdrawal or settling. I test it once more. I raise my hand to shoulder height and move it to my right, slow, smooth. The visible portion of the eye shifts. The lid margin trembles slightly as the globe underneath tries to follow. The grinding in the neck resumes low and wet and controlled. The head begins to turn. Not much. A few more degrees toward my side of the table. The cervical structures resist. The tendons in the front of the neck stand out. The skin at the jawline creases. The sound is worse than anything I've heard so far tonight. It is not a clean pop. It is not a sharp break. It is a steady dragging friction, like fibers are being forced to stretch past the point they were ever meant to. I take a step back. My hip hits the auxiliary tray. The force is not hard, but it is enough to knock a pair of forceps and a scalpel handle off the edge. They hit the floor with a clang that feels too loud for the size of the room. I do not pick them up. My pulse is in my throat now. My breathing is shallow. I realize I am standing with my back almost against the far counter, as far from the table as I can be without leaving the work area. The head finishes the slow arc. It stops when his face is turned enough that if his eyes opened fully, they would be looking straight at me. The eyelids flutter again. Then they hold. The slit of exposed eye surfaces aligns with my chest. I don't move. The air pressure shifts. The stainless tools left on the tray give a soft, continuous vibration against the metal surface, as if a low-frequency current is going through the table. The metallic tick is gone. In its place is a quiet, persistent tremor. I force myself to do one thing that resembles normal work. I reach for the temperature probe. I cross the distance to the table with slow, measured steps. Gloves intact. Mask intact. Nothing in my appearance suggests anything is wrong if someone were to look through the small, wired glass window in the door. I place the probe against the skin at the temple. The monitor beeps. 38 degree, no deviation, no sign that any of this has a thermal correlate. I take the probe away. His eyelids tremble again. They open a fraction wider. For a moment, there is enough of the pupil visible that I can see the edge of it. It is fixed, dilated, flat, everything a dead eye should be. The movement is not in the pupil. It is in the globe. My throat tightens. I take one more step back. The wet grinding climbs from the neck to the base of the skull. I hear it in a way that bypasses my ears and goes straight into the bones of my face. The head makes one final small adjustment. It tilts down just a little, enough that the slit of the eye lines up with my face, not my chest. The temperature in the room feels even lower. That could be perception. The monitor still reads 38 degrees. The numbers are small, constant, and different. I reach for the recorder. My hand shakes as I pick it up. The tremor is fine but obvious when I hit the button. 0320, I say. My voice is hoarse. Cervical rigidity no longer consistent with postmortem timeline. Cranial movement observed. I look at him while I talk. Eye tracking present. No known postmortem mechanism can account for this at current temp and time since death. My breath hitches on account. I do not correct it. I stop the recorder. There is still one place I haven't looked. The door. In 14 years, I have never left a case unfinished once I started the prep. Not for a break, not for a call, not for anything. You learn early in this line of work that you finish what you start. Families upstairs expect their dead to be ready. State inspectors expect logs to be complete. Directors expect the prep room to be efficient. I am aware of all of that as I take the first step toward the door. The tools are still vibrating softly in the tray. The wet scrape under his neck resumes low and paired with a faint creak in the headblock. I do not look back yet. I reach the door and place my hand on the handle. I hesitate. If I leave, the camera will show that. The logbook will show a gap. Anyone could ask why I stepped out with the prep unfinished. I could say I needed a supply. I could say I needed to check a form. I could say anything. Behind me, the vibration in the room stops. The silence returns all at once. It feels like I'm waiting for something. A sound, a final movement, a reason to stay or a reason to run. None of those come. I open the door. Cold hallway air meets the colder air from the prep room. The pressure equalizes in a small rush. The building at this hour is empty above us. The visitation rooms are dark. The lobby is dark. Only the night lights by the front entrance are on. I step out. For the first time in 14 years, I leave a body on the prep table with work still to be done. I do not close the door all the way. The gap is small but enough that I can see a sliver of the room when I turn my head. A line of light, the edge of the table, part of his shoulder. I shouldn't look. I know that. I look anyway. In that narrow frame of view, his head is angled even further toward the door. The rest of his body has not moved. I close the door. Later, when I try to explain to myself why I walked away, I will list a dozen technical reasons safety checks equipment concerns policy references that never actually existed. The truth is simpler. For the first time in my career, I believed that the body on my table was not done responding to me. And I knew if I stayed in that room 1 minute longer, I would respond back. By the time I saw the footage, I had already left him alone once. It was 09:12 a.m. when the owner called me into the small office off the prep hall. Same building, same white walls, same overhead hum, just warmer. The morning staff had turned the thermostat up for the visitation rooms. The CCTV monitor they installed for state compliance sat on the desk, its blue standby screen waiting. "We had a power flicker around 3, he said. "I just want to make sure nothing dropped." That was all he asked me. I sat down in the chair, still in my scrubs, still in the same shoes I'd worn when I walked out of the prep room at 03:20. The smell in here was coffee and paper, not disinfectant and steel. He clicked the mouse, woke up the system, and loaded the feed for Prep Room 1 from the night before. The metallic tick was waiting in the audio. You don't hear it right away. At first, it's just the ambient sound of the refrigeration compressors, or the faint whine of the pump when it kicks in my own voice, dictating times and temperatures. Then underneath it, a sharp tap. Then another. Then the sequence I already knew by heart. Tick. Pause. Tick-tick. The video never moves. The frozen frame shows my back slightly hunched, standing at the head of the first table. The man's face is turned just enough that the profile is visible. The time code at the bottom of the picture reads 02-4103. I watch myself on screen, motionless. I listen to myself talk over the audio moving around a room that on the monitor never changes. Refrigeration temperature remains 38, my recorded voice says. No external vibration source visible. On the screen, my shoulders don't rise or fall. My hand doesn't move. The scalpel in my gloved fingers stays in the same place. The owner watches for about 20 seconds, frowns at the picture, then at the clock on the wall. "Looks like the frame buffer froze," he says. "At least the audio's there." He doesn't hear the wet scrape yet. I do. It comes through the small office speakers at a low level riding under my voice. A sliding internal sound that doesn't match anything mechanical in that room. I feel my throat tighten. I swallow once. "You want me to pull the clip for the board?" he asks. He's talking about the Ohio requirement to retain and produce documentation if there's any incident falls mix-ups, anything that could be tied to handling. Some inspectors like video more than paper. "I'll export it," I say. My voice is flat. Professional. I know the timestamps. He nods and leaves me with the monitor. The door closes. The office gets quiet. I rewind the footage to 02:35. The frame doesn't change. It's still my back. Still the same angle of his head. Still the same small reflection of the wall clock in the stainless tray. The time code reads 02:35:12 now. The audio starts again. My voice steady announcing cavity work. The hum of the pump. The adjustment of instruments on the tray. Then the first metallic tick. On the audio, I pause for half a second when it happens. I know that because my sentence breaks in the middle. You can hear the gap. On the screen, there is no break. The image doesn't flicker. The hand holding the scalpel stays at the exact same height. I let it play through. The abdomen movement isn't visible. The chest movement isn't visible. The change in livor isn't visible. The only evidence is in the things I say and the sounds under them. Livor no longer fixed my voice notes. Pooling appears to be draining toward inferior regions. On screen, my shoulders never shift. The man's face never changes. I watch the time code tick forward, 02:36:01, 02:37:22, 02:39:45. The picture remains frozen at 02:41:03. I rewind twice, 3 times. The system shows the same frame every time. Only the digital counter underneath runs backward. I open the export panel, select the segment from 02:30 to 03:10, and save it to the funeral home's external drive. That's what the policy says to do. Then I copy it again to a second folder and put that copy on a marked thumb drive in my pocket. That part is not in any policy. By 10:00 a.m., I am home. My apartment is 8 minutes from the funeral home, on a good day 15 on a bad one. Ground floor, 2 rooms, quiet. I never minded the quiet before. I shower. I change. I make coffee I don't finish. My hands go through the motions of a day off while my head stays in the prep room. At 10:37, I plug the thumb drive into my laptop. The screen light is softer than the fluorescent in the office. The color palette here is beige walls, dark couch, the blue of the laptop desktop. No stainless, no tile, no formaldehyde. I load the file. The first frame is the same, my back, his profile. The time code 024103. I check the file properties. Duration 40 minutes. Audio intact. Video present but obviously corrupted. I could stop here. I don't. I hit play. The sounds are clearer on my laptop speakers. The suction pump noise is sharper. My own voice sounds closer. When the metallic tick comes, it feels like it's inside the room, not the recording. Tick, 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 tick. I listen to the abdominal movements I described aloud. To the chest movements, to the times I said 38. To the pause when my jaw clenched and I didn't want it on the audio. Then I reached the part I walked away from. 0320, my recorded voice says. Cervical rigidity no longer consistent with postmortem timeline. Cranial movement observed. Eye tracking present. I remember saying those words into the recorder. I remember watching his head turn. I remember his eyelids following my hand. What I don't remember is what comes next on the audio. There is a long pause. Then quietly under my breath, the recording picks up 5 more words. You're trying to sit up. Hearing my own voice say that in my living room makes something in my chest go tight again. I don't remember saying that line. I would not have dictated something that subjective into an official prep room recorder. That's not how we're trained. I replay the segment. Same thing, same pause, same 5 words. On the screen, the time code under the frozen image ticks from 024058 to 030003 with no change in the picture. My jaw clenches. I force it to loosen. I move the playback slider back by 30 seconds and play it again. Same phrase, same tone, same voice. I stop the file and listen to the silence in the apartment. It's normal apartment silence. Distant traffic. A pipe somewhere in the wall. The faint hum of my refrigerator. No prep room. No compressor. No tools. I start the file again, skip ahead to 0255. The wet scrape that I felt through my gloves in that room is now just a sound in my laptop speakers. It is quieter here, but it still carries texture. The kind of noise that should require direct contact to perceive. After the scrape, there is a slight clatter on the audio, the sound of instruments in a tray hitting each other. I remember that part. That was when I stepped back and hit the auxiliary tray. I let the file run until the end. When 0320 comes again, I pause it. I step away from the laptop and stand in the center of my small living room, breathing evenly. For about 30 seconds, I consider deleting the file. Drag it to trash, empty bin, be done with it. Instead, I close the laptop a little harder than I mean to. Not a slam. Just enough that the lid clicks sharper than usual. That's my one frustration. It lands in the room and stays there. I turn the TV on without watching it. I leave the laptop on the coffee table with the thumb drive still in. I make myself sit on the couch and stare at some morning talk show about schools and weather until the images on the screen are just shapes. By noon, I call the funeral home. I tell the owner I want off nights. I don't give him a detailed reason. I say I'm burned out on back-to-back removals. I say my sleep schedule is shot. I say whatever sounds closest to the truth without touching it. He hesitates for a second, then agrees. Day shifts are open next month, he says. We can move you then. We never get that far. 2 weeks later, after 3-day shifts and no nights, I hand in my notice. I cite family reasons on the form. That's what people expect. They don't ask many questions when someone who's been around as long as I have says they're done. I don't tell them the real reason. The real reason is that even on days walking past Prep Room 1 and knowing the table is still in there is enough to make my throat feel tight. I leave the job in late spring. By then, the formal policies and the CCTV requirements and the logbooks are someone else's problem. The building stays where it is on the edge of Franklin County. Families keep coming. Bodies keep coming. The prep room keeps running. The sounds do not stay there. The first time I hear the metallic tick in my apartment, it's a Tuesday night. I'm not on any shift anymore. I'm on my own couch. The TV is off. The laptop is closed. The thumb drive is in a drawer. It's 01:47 a.m. I know because I checked the microwave clock in the kitchen just before lying down. The apartment is quiet. Then from the wall to my left, near the baseboard, I hear it. Tick. Pause. Tick, tick. It is sharper than any pipe noise. Not like settling wood. The sound profile is wrong. It is metal on metal with a tight resonance that doesn't fit this building. I stay very still. I tell myself it's someone banging something against a railing outside, or heat kicking on in another unit. Anything that keeps the sound out of my living room. It comes again. Tick, tick. Pause. This time from the ceiling. I get up and check the vents. I check the radiator. I check the small metal legs on the TV stand. I touch everything that could have an answer. Everything is still. I stand in the center of the room, breathing slow until the sound stops. It doesn't happen every night. Some weeks I don't hear it at all. Then 3 nights in a row it will tap once from behind the fridge or the bathroom door hinge or the frame of the bed. The pattern is always the same. Single taps that mean nothing. Then the old sequence. Tick. Pause. Tick, tick. I do not record it. I do not measure decibels. I do not write those incidents down. I try to make my world smaller instead. I stop driving past the funeral home. I take the long way around town to avoid it. I unsubscribe from the state board's email bulletins, so I don't see the names of the inspectors anymore. For a while it works. Then, about 3 months after my last shift, I decide to clean out the box of old work things I brought home. It's a small file box in the back of my bedroom closet. Inside are copies of my license renewals, a few old OSHA certificates, some inspection notices, and 2 notebooks I used before we went fully digital with logs. I sit on the edge of the bed with the box between my knees and flip one of the notebooks open. Most of the entries are routine. Name codes, dates, times. Cavity work completed, no complication. Livor fixed, viewing safe. Short clinical shorthand I could almost write with my eyes closed. Near the back there is a page that has no date printed on top. It has a time instead. 02:41. Below it in my handwriting is a single line. Body attempted to sit up. Head blocks shifted. Table creaked. I stare at the words. I read them again slowly. The writing is mine. The formation of the numbers. The way I cross my T. The spacing. There is no doubt about that part. The content doesn't match anything I remember documenting. It doesn't match the official log for that night. It doesn't match the audio I listened to. I never attempted to sit up anywhere formal. The time, 02:41, matches the frozen frame on the CCTV. The moment where the picture got stuck. I run my finger under the line without touching the ink. My hand is steady. My breathing is not. In the living room through the wall, I hear the apartment's refrigerator cycle off. Then very softly from somewhere behind the headboard, I hear it. Tick, 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 tick. The same tight metal-on-metal sound from the prep table legs. Except there is no steel in that wall. Just studs, wiring, and pipes. I close the notebook. Not fast, not slow. Just enough pressure that the covers meet with a flat final sound. I put it back in the box and push the box to the back of the closet until it hits the wall. I stand in the bedroom doorway and listen. The apartment is quiet again. I will never work in a prep room after that. I will never stand over another table with a scalpel in my hand and a recorder at my side. I still know the numbers. I still know that at 38 degrees Celsius, 14 hours post-mortem with livor fixed and rigor fully set, none of what I saw and heard should have been possible. But the sounds I heard in that room don't care about what should be possible. They found new surfaces, new walls, new metal. Dead bodies shouldn't follow you home. But some sounds never stay in the morgue. If you stayed with me until now, you felt what I felt in that room. If something in this story stayed under your skin, hit like so, I know you heard it clearly. Share this with someone who needs to hear the sound for themselves. And if you want to follow the cases, I'll never forget subscribe and keep the lights low. Before you go, tell me in the comments, was it a reflex? Or was it trying to sit up?